And I'll hand over to Georgina now just to give you a bit of context and the rationale for group clinics. Georgina,
Hi.
over to you.
Hi, thanks. Can you hear me okay, Alicia? Just to check. Yeah.
Yes, we can. Yeah.
Brilliant, fantastic. So next slide. So usually where group clinics fit into care pathways is in the category of what we call simple care. So in the context of weight management, actually this does work really, really effectively. So care that is planned and routine, driven by a guideline or a protocol. So if you think about GLP-1 prescribing, weight management approaches, they're quite driven by guidelines and protocols. So NICE has, for instance, a set of guidelines on what you should do in a review appointment, what you should do in an assessment appointment, and where the patient themselves has to undertake some self-management or make lifestyle change or support themselves through some kind of rehabilitation program. So actually you can see that it works really well for a weight management pathway. However, the good news is that group clinics also impact on all three levels of this triangle, because when we do group clinics for some of that more simple care, that routine care, it actually releases clinician time to spend more time with people who are more complex and who need more of their one-to-one attention. And because within a group there are 12 behavior change mechanisms that are not present in a one-to-one appointment, it also has a bigger impact on the self-management, self-care that people do the majority of the time, because obviously they're actually only with us for a very short part of their lives. So what they're doing outside of the group clinic, outside of the one-to-one appointments that we have with them, is what really impacts on their change in their lives and the change in their health. And so knowing that you've got the mechanisms, 12 mechanisms available to you in a group clinic, explains why the research shows that people who are seen and followed up in group clinics make more behavior changes than people who are followed up in one-to-one appointments. Next slide, please. So just to say that for those of you who work in a general practice environment, group clinics are also recognised as part of modern general practice, particularly in relation to long-term condition management, and are described in this guidance that was issued in 2024-25 as a personalised care approach to long-term conditions management. In that document, they're described as shared medical appointments. That is another name for group clinics. Next slide. And there is a wealth of evidence. It's been growing over the last 30 years that supports this way of working. In fact, there are I always get this slightly muddled up. I think there's over 10 systematic reviews of group clinics, and those of you who understand about evidence will know that a systematic review is usually only a very high quality research papers, and it's like a review of the research. So if there are that many reviews and they show the evidence that I'm going to just run through with you now, you can see that there is a really robust evidence base behind this way of working. So these benefits are all compared to one-to-one appointments. So the evidence shows an increase in QOF compliance of a group clinic model versus a one-to-one. Nurse time being freed up. So for every 500 patients managed, long-term conditions patients managed in a group clinic, you free approximately a 0.5 full-time equivalent nurse. And also improved biomarkers in diabetes, HbA1c and blood pressure, improved quality of life, improved knowledge of their condition, higher levels of trust in the clinician, and a perception that the care that they're given in a group clinic is higher quality than the one-to-one care, although when compared from a clinical perspective, the care is the same. So it's about a perception of higher quality, not an actual higher quality clinical care being delivered. and better experience of people and caregivers. So just to reinforce that last point, the quality of care is equal in a one-to-one appointment and a group appointment. Next slide, please. What we often forget, perhaps, particularly at the moment when we've got a system that's in a little bit of turmoil and everybody's going through a lot of change and transition, is that we do need to also make sure that our staff have a great experience of caregiving, because it's directly related to safety, and it's also directly related to patient experience. So if our staff have a good experience of delivering care, it actually improves the patient experience of care, because happy staff means happy people. And the evidence around this in relation to group clinics is emerging, and shows that when clinicians are involved in co-designing the content of their group clinics, it restores a sense of autonomy to them in terms of delivering and designing care that they may sometimes experience as quite repetitive, and not feel that they're adding a lot of value to those conversations. It gives them a deeper connection with their patients, and it also restores joy to practice. And this is something that we hear consistently when clinicians switch over to the group clinic model. And all of those things, the evidence would suggest, are highly likely to impact positively on staff retention. So particularly in primary care, where we're doing, lots of things like cough reviews, which can be quite repetitive, swapping to the group clinic model can be really good for your well-being, your staff well-being. Next slide, please. So just to make a link to the shifts that are signalled in the 10-year plan, group clinics actually supports all of them. So it helps to create a vehicle for integrated neighbourhood working through something we call neighbourhood group clinics. It increases capacity and productivity outside of hospital, and it has been shown consistently to reduce waits for services very quickly. When they're introduced within months, waits can go from 3 to 4 months down to a couple of weeks. There's a shift as well from analog to digital, and the video group clinic model has been shown to be a more engaging way of delivering and introducing video care, particularly in primary care. And it's a digital accelerator for the whole team, because everybody is involved in the group clinic model. And then illness to prevention, which is, I guess, what we're really kind of focused on today. And the group clinic model really personalizes the experience. It frees time, it releases time for that prevention conversation, to embed lifestyle medicine into clinical practice, and because it has a greater impact on client patient behavior change, that in itself is obviously helping to support prevention. It also enhances the experience for the caregivers, which is also potentially part of prevention, and also enhances communication with formal care, family carers, which is very, very important, particularly when you're dealing with people with complex health issues, because it's 20% of hospital admissions are down to the carer breaking down, as opposed to a change in the patient's clinical condition. Next slide. So just to also highlight that all of these aspects are recommended by NICE as part of the behavioural change process within within sort of any healthcare intervention that is aiming to deliver behaviour change at an individual level. And all of these things are actually part of a group clinic. So NICE hasn't written any recommendations on group clinics, but this is its guidance on how to achieve behaviour change for individuals. And you can see all of those elements are present in a group clinic. Next slide, please. So just a quick bit of thought provocation for you guys before we hear from our speakers. So we did a bit of work last year to look at the GLP GLP-1 pathway and think about where group clinics might be used in terms of clinical wraparound care, as it's called, for those who are on a GLP-1 for whatever reason. And we came up with these different ways that you could use a group clinic. So not that you have to, but these are things that we have actually co-designed with input from national experts. So you could have a pre-treatment engagement event, which is not actually a clinical appointment, but explains what the GLP-1 is, that the person is eligible, and to help support them to make an informed decision. You could do part of their assessment as a group assessment to look at some of those low-level acuity risk things, which could shorten the need for a one-to-one assessment with patients, because they would come pre-ready to kind of take the decision and maybe share issues around why, weight management has been an issue for them throughout their lives, that might go back to adverse childhood events and that kind of thing in the one-to-one. You would also potentially be able to use a group clinic for planned monthly reviews. The 6 monthly group review could also be a group, and you could also do a discharge group appointment. So there's not much of the pathway that couldn't be used to support you with a group clinic model. And you'll hear a bit more about that from Zara in a little bit. Next slide. So, Katharine, over to you to give us that sort of policy context around the group, the weight management policy.
Thanks, Georgina. I think before I start, I just have to say I am a big advocate for the sort of group clinic approach, and I think the resource side of it is really important. But I think it benefit that comes to patients as a group when they are together, it can't be overlooked. And I do really agree with Georgina that the stresses and strains that we're seeing at the moment, the volumes, etc., this is a really, I think, worthwhile investment in endeavour of time to really get to grips with, can this help in practice with your patient populations? So from a national perspective, obviously we advocate where a clinical group session can be used if it's possible, of course, but we've used that learning and that group-based behavioural change sort of understanding to develop new services to support patients who are receiving prescribing for obesity. Currently it's tirzepatide in primary care, Mounjaro, I'll say it feels like a dirty word sometimes when I say it. Next slide, please. But what we have really is a challenge with 3.4 million people who are actually eligible to be for prescribing of the weight loss drug. That's an incredible amount of time. So what we need to think about is, how do we use time and how do we meet the patient's needs and what is required of those patients? Next slide, please. So when we look at the actual pharmacotherapy itself, we've actually got two types of support. We've got the clinical support, which Georgina has touched on. So we're looking at that prescribing, the reviews, etc. And also sort of management and monitoring of comorbidities, but also there's the behavioural support. So that drive of healthy behaviours, changing lifestyle, and really structured interventions to support those people on the pharmacotherapy. So those two elements together are actually wraparound care, but we've got two elements of it. Now, we don't mandate from a national perspective how that clinical support is delivered or the behavioural support from some respects, but what we do have is the national approach and national programs that we can deliver using the idea that sits behind the group clinic approach. Next slide, please. We have quite a lot of experience in delivering programs just generally. Certainly the diabetes prevention program is well known to all. But what's interesting about this is we actually have an in-person group delivery of the program. We have a remote group delivery of the program. So like we are now through this sort of interaction using technology, and then a digital intervention, which I'm not going to talk about today. but there's 3 options for patients to actually engage, and it's the group side, that in-person and that remote, that is really important. And one of the key things about the diabetes prevention program with the remote group is that they've been tailored to date. So we have patients, whether it be tailored through language or ethnicity, sex or age, depending on the requirement of the area. And what we're doing now is using this learning to actually apply it to the behavioural support element, the behavioural support wraparound care for obesity prescribing. Next slide, please. The big key change is actually we're using that tailored remote approach and actually opening it up to all as a remote approach. So we're going to become more group friendly to a wider cohort of patients using technology, which also supports that shift that Georgina was talking about. But we're unlocking the power of the group-based support for obesity prescribing, really. So we're drawing on the experience we have with our delivery providers. Those partners, those providers, they already deliver so much that is incorporated in the group approach. So for instance, I like to think of it as more of a mixed model, in the sense there is group education because that is part of the service, but the actual group approach of the support, the goals, the discussions, you saw the discussion board that was shared earlier in the presentation when we first started. That is still utilised within the services, and we still have healthcare professionals and facilitators delivering services. So it's very much a similar model that we're and bringing the principles of that group into that one approach in the group. But there's still the opportunity for participants to break away, have a one-to-one conversation, and there's not always the opportunity to discuss everything in a group or to bring out questions, but that support that it brings sometimes enables people to have that one-to-one discussion with the facilitator or the if it's a healthcare professional in the session as well. So really the behavioural support isn't starting from a blank piece of paper. We're utilising what we already know and the developments and understanding of the group-based support to really deliver something, I think, that will demonstrate that we can meet a wider volume of patients in a similar way and utilise that group clinic approach. Next slide, please. One of the things we really like to think about is when we're talking about the benefits. Yes, we have a national reach for the programme, but that structured group support can really be delivered effectively at scale. So from a national reach, we see it, but that doesn't mean everything has to be on a national scale. We could be talking across different footprints, ICBs, PCN, so the same principles applied. But we do consider that flexible delivery option is really important. So we've got 2 different group approaches, but we also have that digital approach. And for us, that is recognising that it isn't for everybody, the group approach. And that's exactly what Georgina was saying. There is a flexibility in there that we meet. So there is that self-directed option from us. And we are meeting different needs and preferences. But really, peer learning, peer support, that group-based is something that our attendees really appreciate. Sometimes it's tentative to start with. It's different for some people. I myself had never been to a group-based clinic before, and I think I might have shared this with Georgina. I went, and all the preconceived ideas I had were wrong. And this is the feedback we're getting from our patients. They are thinking about, are we going along to a village hall, being weighed, given stars, and off you go. When they attend, they realise there's a lot more to it than that. And there is the ability to be with people as well. And you really can't underestimate. It's not just about resource, it's about humans and how we interact and the support that comes with it. Next slide, please. So using those principles, really, we're looking at like a structured program of behavioural change with the opportunity for it to be delivered in a group setting. And it covers a lot of content from an educational perspective, But what we have is the ability to drive conversations around those topics through the group, to actually draw out what may not actually be shared on a one-to-one basis. And education can become very passive, whereas group working and group discussion and group support actually brings out more. And we know that the opportunities for shared learning, for encouragement and accountability, they help our participants remain engaged, and actually it really supports them genuinely. Next slide, please. One of the value that comes out, though, that we've seen is helping people to stay motivated, connected and engaged. So we know from the experience of the diabetes prevention program and also other national programs what people need. So it is that motivation, the confidence, the support and long-term engagement. But the group-based sessions that we have, they deliver those in a different way. So it is that peer encouragement and support, the shared learning, but through discussion, not just passive sort of absorption of facts and direction. It reduces isolation as well, and that's something that's come out with some of the focus groups we've done, the reducing the isolation of people alone, but also feeling that you're alone and feeling that actually this is something I can't really talk about. It enables people to draw out of themselves, and I think that's really powerful. Goal setting as well. So there is set, you know, not everything's done in front of everybody, as Georgina said, but having a shared goal, whether that be attendance. With the weight loss drugs, weight loss itself is not the goal. It's that change in you, that lifestyle, that behavioral, that understanding, and that is the goals within the sessions. And it's really helped sharing some people's goals may be around physical activity, being able to walk up and down the stairs 3 to 4 times, but it starts making other people think actually it's only about the small changes. And that's the sort of benefit that comes with it, understanding others and to understand yourself, and that ongoing interaction, which I don't think can be really discarded. And we know of groups within the diabetes prevention program who've been together, have actually retained in touch with each other, and it's an ongoing support, which is in a one-to-one. That's not really something that really develops. But for us, that choice does remain separate. So it's a choice of how the group is done, in person or whether it be through remote like this, which can really help with people's time, travel, disability. Having the ability to be like this is really beneficial. But also there's still that self-directed sort of digital support one-to-one, if that's what the patient would prefer. Next slide, please. But I think one thing we can't deny is the value of connection, accountability. These are some of the quotes we've collected from our focus groups and our feedback from our patients. And I've only selection, but open up is something that comes up time after time after time. The ability to open up and the ability to feel that you can discuss anything. We've heard from people who never felt they would be so open as they are in a group session, and feel that they wouldn't actually be as open as they are in a one-to-one with the clinician. And I actually think that's really important and really powerful to consider if you're delivering services from the clinical wraparound care element as well. Having a group and that bringing to the surface and the trust and the sort of people find themselves talking about things that they never thought they would. And I think learning from others and understanding that there's similar challenges. This is another theme that comes through, that the group support mechanism and that delivery approach really does draw out. So I suppose that combining the evidence-based support with the opportunities for that connection, for group and shared learning and shared experience can't be underrated. And from a retention perspective of our group-based sessions, our group-based delivery, we're actually seeing a really good retention rate, higher than we've seen on the diabetes prevention program when we look at month on month. And it's the content, it's the delivery, and it's actually the way that it's been approached with that clinical and the behavioural. Next slide, please. So really using our knowledge and skills from combining that sort of medication and behavioural support, hopefully it provides the service users and the patients with a overarching delivery, an overarching service. But if they are taking part in a in-person group or a remote group, there is the possibility that actually when a clinical group is put to them, that won't seem so alien. And it's almost paving the way for some people, some patients to participate and see this as the norm in a clinical setting if it's not something that they've done before. So really, I think seeing both as a benefit to each other is really important. And this is my last slide, so don't panic coming up. So next slide, please. And Georgina's already sort of touched on this, but the group-based approach, it does extend beyond behavioural change programs likewise in the benefits. We talked about the patient experience, I have the peer support and scale, but there's certainly workforce consideration. So optimising the workforce, the capacity that you have. And I think just generally we are being asked to do more with potentially less, but this can be a beneficial way to patients of actually achieving that. I think access and equity, yep, definitely that flexible pathway approach, and to reach and engage with people more fairly by perhaps tailoring the groups that are run is really important. And also value, and I know it's always a dirty word when we talk about money, but there is sort of high quality support can be delivered in a cost effective way by using the sort of group based approaches, whether it be in the clinical or whether it be in the behavioural wraparound, and that is of interest. And I think the opportunities that are offered, we really need to look at them going hand in hand here and really promoting that group-based support and allowing patients to try, because I think genuinely they will be pleasantly surprised, but always having the option that if it's not for them, there can always be that one-to-one. And that's the ethos of our program. And I think with the clinical side of it, where some of the general practices we're speaking to about how they're running their the clinical wraparound care, that's how they are applying it as well. So that's
brilliant.
all for
Thank
myself.
you so much, Catherine. That was really good. I'm going to save the questions in the chat until a little bit later, but do feel free to, there's a couple of questions there to you that you might want to just answer in the chat yourself if you want, whilst we go on, because we're a little bit behind on time. So so Mark and Zara, I'm going to hand over to you. If you can definitely keep it within the 10 minutes, that would be amazing. Thank you so much, Zara.
Good afternoon, everyone. As has already been said, my name is Zara Gandon. I'm a GP partner in Stoke-on-Trent. And I just want to tell you a little bit about a wraparound GLP-1 service that we have run. So for those of you that don't know, Stoke-on-Trent is quite a highly deprived area. We've got a 9.2% actual list size. Our weighted list size is over 11,000, which shows you the difference in the state of the patients. But we have had a real issue in the growth of our diabetic patients. Interestingly, our ethnicity doesn't match our area. Our local area is increasing in its Asian population, and yet we have the fastest growing diabetic register in the area. Some of that might be the way we diagnose and pick it up, but we just suddenly became aware that we are having a crisis, and what are we going to do about it? We also had 27% on our obesity register, and we had 0.5% eligible for GLP-1s in the NICE 1 tag in the cohort 1. So real high issue of comorbidity for us as a practice. Next slide, please. So we thought, what are we going to do about this? This is an epidemic. This is exploding. And as a practice, we have become more and more interested in lifestyle medicine. For those of you not hugely aware of lifestyle medicine, do go onto the British Society of Lifestyle Medicine website. So it's all about holistic, whole person care. It looks at there are 6 pillars of lifestyle medicine, which are to do with eating, movement, sleep, mental health, positive relationships and avoiding things that cause you harm. So really holistic care of patients. And we had become more and more interested in this as a practice. Actually, if we spend so much of our time putting sticking plasters on patients rather than actually grassroots change. But if a patient isn't sleeping, then you've got no chance of their diabetes being controlled. If their mental health is low, you're going to struggle. So it's all about that holistic care. So we came up with this project in collaboration with our ICB and our local council, our surgery, and we use the content of the Lifestyle Medicine Accelerator run by Dr. Cami Hirons, who is just created this fantastic resource. Again, have a look online to help patients journey through each pillar of lifestyle medicine. So we designed a program where patients would come as a group consult, a maximum of 20 at a time. We hired a local snooker hall, and we did 6 sessions over 12 weeks. We seconded a health coach from the local council. We didn't use one of our staff just because the one from the council was also trained in exercise, and we wanted this course to practice what we preached. So we wanted to incorporate movement, both cardiac and resistance, into the evening. Now, to get our patients along, we needed a hook. So therefore, in collaboration, we got permission to offer Mounjaro at practice level to the patients who were eligible for it. To get it, they had to attend 5 of the 6 sessions. They had to have 3, 6, 9, 12, and 24-month reviews and stay with us on the journey. Next slide, please. So we went for the most of the standard Mounjaro prescribing rules that you'll be aware of. We just added in, we wanted them not to be particularly frail, just so we could see max benefit in this program. Next slide, please. So patients would come. This is John. He was the coach that we seconded. They would come and he would deliver the content. Myself and one of my colleagues would be there to do the dose adjustments. We did initiation and then we do dose adjustments as we were there as well. We would have whole conversations checking in how patients were with the medication, what was going on, as well as educating them on these 6 pillars of lifestyle medicine. So John would do the education, and John would also do 30 minutes of graded exercise each week. And the benefit also of seconding a health coach from the council was that patients actually got discounts on courses at the local council gyms and a cheaper membership to get them in. Next slide, please. So I'm trying to stick with my 10 minutes as I've been asked. But a lot of what Katharine said, I can really echo. You know, the patients walked in on that first night. They were terrified in reality. What have I signed up for? What am I doing? Is this really going to make a difference? Am I just going to be fat shamed again? But they gave us a try. And I've been a GP now for over 10 years, and this course has genuinely been the highlight of my career. I've genuinely, for the first time probably ever, seen patients' lives changed. By the time we got to week 12, patients were crying, and I still know these patients so much better than I know my general patients, and it's been a joy. And we also created a signal group similar to WhatsApp, but just a bit more compliant with GDPR, that they could encourage each other, and that group is still going now. So as you can see, just wanted to show you some results. We saw a 28 millimole drop in HbA1c. You'll see in the graph that some of the HbA1cs rebounded. These are the patients that couldn't tolerate Mounjaro. If you take out the patients who, from the results, who couldn't tolerate Mounjaro, the drop actually goes to an average of 40 millimoles. in HbA1c, which is 10 greater than the research studies expect for the dose that these patients went up to, which shows the added benefit of the lifestyle and the wraparound care that we gave them. Next slide, please. So again, you can see a statistically significant average weight drop of 8.9 kilograms. These patients, do you know their one complaint on this course was, it's expensive because I have to keep buying new clothes. So it was just an absolute joy. Again, the rebounds are those who couldn't tolerate Mounjaro. Next slide, please. Again, following a similar trend with waist circumference. Next slide, please. So for me, I didn't want to just look at those biometric values. I wanted to ensure we're actually making a difference to these people's lives, that the lifestyle information that we included was making a difference. As you can see, at 3 months, sleep was improved, was statistically significant. Fruit and veg, still significant at 9 months. Mental health improved at 3 months and then dropped off. I do wonder whether that's a link that at 3 months was when we finished the course. So they were still coming every fortnight. They were bonding. They felt like they were in this shared space that they could own and see health benefits. Physical activity wasn't statistically significant, but I think that's actually to do with the way we coded our data. But for me, the most important thing is these patients, these 20 patients, still feel in control of their health 9 months later, and a difference in there. Next slide, please. We also looked at dialogue scores, looking at how satisfied they were. The ones in larger print are the ones that are statistically significant. Again, friendships, medication, physical health, mental health, just all improved. And I saw one of these patients last week, and they just can't stop thanking us for the difference that we've actually made in their lives. Next slide, please. So in conclusion, as I've already said, it's a whistle-stop tour. I will look at the questions in a sec, but to try and keep us all to time, this is the best job satisfaction I have ever had. Fascinating thing is that as a practice, as we entered this program, we've seen a change in how our staff also approach their own health. And everyone has got much more interested in lifestyle medicine. Everyone has got much more interested in what they're eating. You know, we have jokes in the staff room about how many different plants are in your plate. A lot of our staff have lost weight alongside this. So group clinics, group consults genuinely do make a significant difference has made a significant difference to our patients, to our staff, and I would very much encourage any of you who are considering to do the green light and to go for it. It's been highly satisfactory. There you go, Georgina. I hope that has been a whistle stop.
You're amazing. Thank you so much, Zara. We have got quite a few questions for you, so I'm hoping you can stay. And we'll pass on to Mark now. But thank you so much. You've got us kind of a little bit back on track, so that's brilliant. Thank you.
But
Mark,
don't worry, everyone. I will answer your questions at the end.
Yeah, and do feel free to answer any of the ones in the chat if you want to in the meantime.
Good afternoon, all. Thank you, Zara. I was really inspired by that. I'm a health coach running one-to-one and group programs at Wokingham North Primary Care Network. And our local council used to sponsor a tier 2 weight management program, but they stopped about 3 or 4 years ago. And so we had this gap. So I wanted to create something that essentially tried to help at least fill that gap. So that's where the idea came from originally, to create a weight management program. But it's not the only program that we do. If we go into the next slide, it's one of, at the moment, 4 groups that we run in the PCN. The menopause one, incredibly popular. Healthy Hearts we run very regularly. People with high cholesterol, for example, or high blood pressure, and the fibromyalgia and chronic pain one, the ability to help people take control of their own lives has been wonderful to see. And the newest one then is this healthy weight management program. So next slide. Weight loss, the problem. Well, it's a big grand statement, the problem. There's all kinds of challenges with weight loss, but there's a really, really common thing that almost every patient that comes along to the group is very experienced in. So the first thing is we go on a diet. I say we, because we probably all experience this to some degree. We go on a diet. We then lose weight, because it's actually, most diets, in fact, will help us lose weight. We then finish the diet, and then what happens? We come off the diet, and very often then we put the weight back on. And so there's something wrong with this process, clearly. And I think fundamentally, the problem is coming on and off a diet. and so one of the ways we want to try and help change how people think about this, build confidence in weight management, is to help people think about how they're going to look after their health forever, which includes how am I going to eat forever? I guess the most significant thing that's involved in weight management. And so this is I guess the driver for the program. So next slide. And so this is the program. There are 6 sessions in the program that we run over typically 14 weeks, something along those lines. The first 2 sessions are all about food, helping people understand food, which is to some degree, I guess, what you'd expect in a weight management program. But then the next 2 sessions, probably the most significant actually of all of them, are the ones about managing mood, or things to do with stress management, emotional eating. Just about every human emotionally eats. It's quite normal, but helping us not overdo that is really helpful. And so that middle section there is probably one of the most significant parts of the program, I think, for most patients. But then you kind of move on to habits. I wish we could do all of these in week 1 to some degree, but we can't. And so, of course, it is really all about habitual, behavior. And of course, wherever we are now, the habitual behavior has taken us to where we are now. So if we want our future to be different, then fundamentally it's about changing our habitual behavior moving forward. And so, again, often that's a few, bulbs in people's heads with that session. And then finally, because we're going to leave them here in the final session, how can you continue this process? Again, how can I eat like this forever? How can I focus on my health like this forever? And so we try and build some of those, and when this happens and when this happens type things in the program. So that's the program. Next slide. The first 3, we're just about to finish the 4th, and we're running the 5th and 6th version of the program iteration of the program right now. The first 3 seem to go well. The average weight loss for people attending was 6.9 kilos. And one of the things I didn't say is that the program is intended for people that are, if you like, fortunate enough to not have the comorbidities to be prescribed GLP-1. So they have to have lots of things that have gone wrong to be prescribed the GLP-1 agonist. But plenty of people want to lose weight that fortunately don't have those comorbidities. And so that's what this program is intended for. Having said that, some people do come along and they have self-prescribed, but it's not to cover, not intended anyway to cover that program, as there are programs already. So about 6.9 kilo, quite variable. We've had one patient that didn't lose any weight, self-confessed, didn't really change anything. What a surprise. And so we all, like anything else, we have to engage in order to make a difference. And it has to be the right time and place, clearly. But it seems to be going well. It seems to be working well for us so far. The patient, one of the things we haven't done yet, we intend to do is to follow up, of course, find out how it is 6 months later, for example. And so that's our next part of the plan. So next slide. And so on the whole, it seems to have gone very well so far. And as we've heard already, as Zara's already told us, as we've heard from Katharine originally, people like often being in a group. And we're certainly not going to stand on scales in front of everybody else and applauding or not applauding. Of course, it's nothing like that. And so the supportive environment, it's an open environment. People can discuss. We can talk about individual challenges that people are having, because often individual challenges are not really individual challenges. Many of us share some of those individual challenges. So we have this kind of combination of it being able to tailor it to specific. There's lots of conversation whilst fitting in the structure of an overall program. So we're trying to do our best to combine those two things together. And I think the middle one, it made me think about healthy eating, not just about being on a diet. I think that says it all for me. That's what we're trying to do. How can I look after my health overall? And one of the things it didn't mention in the 6 sessions, it doesn't talk about exercise. We do actually talk about exercise. But as statistically, exercise isn't the main driver for weight loss, but of course it's really, really important for our overall health. So we absolutely do include that as part of the program too. So this is our program, and let's leave some space for questions. Thank you.
Thank you, Mark. And I just think it would be also, I know sort of quite a bit about your service and the work you do in Wokingham. And I know that when Rupa shares the work you've done around weight management, she does mention that there's the trigger for you sort of setting up the weight management service was the introduction of GLP-1s, wasn't it? Because the practice was getting so many so many requests for, can I have this? And actually, what you did in response to that, which is amazing, is to set up the service you've just described so that, that trigger of GLP-1s coming on the market offered a sort of moment in time for people to actually get access to support. So
Yes.
I think that's a really important point as well, because I bet you're not alone around amongst PCNs having huge queues of people asking about GLP-1s at the door. So you've given them some hope that there's something that they can do, which is really important. So we've got quite a few questions, and I'm just very aware of time. We've only literally got 4 minutes left. So I'm thinking, Alicia, are you thinking I could maybe ask 2 questions, or what do you want to do about time?
You can do 2 if they're quick.
Okay, so Katharine, I don't know if this is going to be a question. This could be a yes or no answer. Just to prompt you. So one of our lovely participants asked, do you envisage integrated behavioural and clinical support in one group rather than 2 separate?
Oh, that could be a maybe. There you go. It's too early for that at the moment. I think just general capacity and understand just isn't there. So a maybe. There you go.
Yeah, brilliant. Thank you so much. And the other one is about health inequalities, the inequalities agenda and group clinics. And I think on that one, what I would just say is that this is an area that is quite under researched in relation to group clinics. But what the evidence does show is that people who are less well controlled, if you like, so people who struggle with their health issues, which is obviously maybe down to sort of external factors and some of the challenges that they have in their lives, do better in group clinics than people who are perhaps more activated, if you like, using that horrible term. And I think that's really interesting, but it is an area where we need to do more research. But potentially, because you can run group clinics in different languages, in community settings where there's more trust, all that kind of thing, it can help to overcome inequalities in theory. And we actually have a whole paper on sort of resource sheet on group clinics and inequalities, and I will put in the chat to send that out to everybody as Alicia closes